Hi, good afternoon, everyone. Thanks so much for joining us today. I'm Marla Moreland, Business Development Executive at Nova Healthcare Administrators, and I'm so glad you're able to join us for our webinar, which is part one in our stewardship webinar series focused on a proactive approach to care. And it's presented by Nova's president, Laura Hirsch. But just a few housekeeping items before we get started. If you have any questions, and we love questions during the presentation, please type them into the question box in your GoToWebinar control panel, and then we'll have time to address the questions at the end of the presentation. So I would also like to take a moment just to mention again that this is the first part of a four-part series. In the upcoming months, we're going to continue to educate our attendees on how a data-driven, proactive approach can be used to deliver the results clients value most, and that's healthier employees and reduced medical spend. These webinars in our series will focus on risk management, plan analysis, execution, and engagement, and we all know how important engagement is to the success of any program, and actionable intelligence. So be sure to stay tuned for more information on our presentations, and we'll, of course, be sending out invitations. So now that that's all covered, let's get started. I'm pleased to introduce our speaker today, Nova's president, Laura Hirsch. She brings more than 3 decades of experience and leadership in healthcare to the table today. Laura, you're celebrating, I think, your 30-year anniversary, aren't you?
Yes, I am.
That's what I thought.
I don't want to admit it.
30 years. Since 2011, under Laura's leadership. There you go. Well, since 2011, under Laura's leadership, Nova's employee base has quadrupled in size, and she's built an organizational structure designed to maximize client success. And it's now supporting over 5 times as many clients as we had back in 2011. And of course, we're still growing. This structure has also enabled Nova to maintain a 99% retention rate over a 3-year period. So we also have today Donna Smith. She's joining us. She's our Director of Product Innovation, and she brings 25 years of self-funded experience to our webinar today. So welcome, everyone. And with that, Laura, I'll let you take it from here.
All right, thanks, Marla. Appreciate everybody attending today. I'm actually very excited about presenting. Trend management is a huge passion of mine. Donna and I have worked together for many, many years, but the last couple of years we've really spent time creating an approach to trend management. We understand that when managing self-funded plans, it's critical to understanding the cost drivers and how we can mitigate those, in order to support our clients that have self-funded plans. So I asked Donna to join me today so that she can pipe in. She has a lot to offer and is also very passionate about the subject. So I'm sure that all of you are joining today because you're faced with the exact same problem that we all are. Healthcare costs continue to escalate year over year. It doesn't seem to be an end in sight, and everybody is trying to find the answer. What is the answer? So today we really wanted to start talking about the causes of the escalating costs. What are the factors? And kind of show you some of the strategies of how you can dig down into the data to understand better about the plan, your plan, and those cost drivers. And then in some of the series that follow, we can talk about the strategies that you can use. So when we first start off, we're looking at the escalating costs. We look at it as though there's kind of 2 different areas. One is the uncontrollable factors that none of us control. It's actually good things, right? New medical technology, new treatments, things that are all benefiting us as individuals, but unfortunately are driving up healthcare costs. On the right side, though, we have the controllable factors, and these are the things that we really want to focus on. And when you look at this list, I think you can kind of see why over the last 20, 25 years, we as an industry on the payer side, right, whether it's fully insured or you're self-funded and you're administering the plan, but why we've created medical management programs, right? So increased utilization and consumer demand, as an example, in fee-for-service reimbursement, have kind of caused us to react and create our utilization management programs, wanting to make sure that all of the services that are being requested are truly medically appropriate. When you think about new medical technology or treatment options and just, you know, the fragmented care delivery, it's easy to understand why we've created case management. It's very difficult for patients to be able to navigate the system, and we on the payer side want to be able to help them and also help to you know, promote quality care, low cost care, so that we can control costs for our self-funded plans. And then lastly, though, unhealthy behaviors, that's what has driven us to focus on disease management programs, right? Because we know that people who are not managing their conditions are those individuals that are going to end up in the emergency room or inpatient hospital, and that is a huge cost driver for all of us. So when you look at these factors, and then you add to it a fragmented care delivery system, so when you look at this picture, you know, imagine the primary care doc is one of these individuals who has no idea when he gives his patient a prescription, whether they actually go to the pharmacy and they fill it, or whether his patient is seeing multiple specialists for different reasons. There's no, you know, there's no connection really when you think about all of the different healthcare providers that are out there. And then when you look at it from the inside, you look at insurance companies or on the administrative side, there's also fragmentation there as well. You typically will have claims teams that are separated from customer service teams, and even the medical management team, most of the time in a self-funded environment, it's actually a separate vendor who provides the medical management, not even integrated within the TPA as an example. And then even within medical management, you have silos or fragmentation where you might have a utilization management nurse, a case management nurse, and a disease management nurse all have their own functions that they provide, and all three of them may be touching that patient all at the same time. So there's all this fragmentation along with all of the other factors, and that's what just is continuing to drive up healthcare costs. So when you look at what's driving the cost from a condition standpoint, this is actually information from the Employee Benefit News, and they're stating that these are the top 10 conditions that are costing employers the most money. But my question is, for any of you, when you're managing a self-funded plan, do you know what the top cost drivers are for that particular plan, right? So, so what that those are the top 10 conditions across the country if it's not the top 10 conditions for the particular plan that you're managing. You may be throwing money away or investing time and energy into managing something that it's really not going to give you a return. So over the last couple of years, we've really developed a proactive, customized approach that I believe applies to anybody who's managing a self-funded plan. And there's kind of 4 areas. And the first one is really on identifying costs. What are the cost drivers? And how do you stratify the risk? So this is where, most of the time when you're in a self-funded plan, whether it's managed through a TPA or a carrier, you're often given reports that will talk about some of the conditions that are, the high cost drivers or the services that are driving costs. But I really challenge you to dig deeper into that data to figure out not what's driving the cost, but why. Why is it driving the cost? So for example, I'm sure all of you that have managed a self-funded plan have been told that your ER costs are high, or it's an expense, right? Even if it's, let's say, below the national benchmark, it still is an expense and people are still using it inappropriately. So the question though is not, that it's the ER driving the cost. So sure, go ahead, you can put in you can increase the copay or the deductible for that. But the real question should be why? What is the underlying reason that people are using the emergency room inappropriately? And when you start to really dig down into the data, you might find that individuals don't have primary care docs, so they don't have a choice but to use the ER. You may find people are using it from a convenience purpose, and because there really isn't a cost differential, so they're going to go after work instead of taking time off, as an example. So it's not just about understanding what the cost driver is. The key is really to understand why. So when we look at cost identification, there's actually 3 different categories that we focus on. One is the medical and the pharmacy claims data. Another is biometric screenings and health risk assessments. And then the third is connected company intel. So we're going to first start off with medical and pharmacy claims. And, again, I'm pretty confident that anybody who has a self-funded plan, you're getting reports from the administrator and they're sharing probably high-level information with you. But the question is, are you able to dig down deeper into that data? So what I really want to show you here is just a couple different types of report or information that where I think that you could dig down deeper and it might be more meaningful and provide more information for you. So you're probably getting information about what percentage of your population is seeking preventive exams and getting the routine screenings. What I would encourage you to do, though, is to drill down into the data to understand those that aren't getting it. Why? Why aren't they? Are they not connected to a primary care? Is it spouses or the employees who are driving that? Is it they don't have time to go, or they think that there's a cost barrier? If you're on a high deductible plan, sometimes they don't realize that there is no copay or deductible. So the key is to really understand who is not having those routine exams, and then you can start to figure out what you can do about it. The next information here that we're looking at is to understand what % of your population is driving what cost. So this is a very high level report, I guess, that just shows the percentage of participants and what cost that they're driving. So in this example, the 1% of the participants are driving more than half of the cost. Well, we're going to want to look at that and understand, is it just 1 or 2 high cost claimants? Is there anything that we can do about that? There may not be, from a case management standpoint, we can manage that, but probably have more opportunity to really, put some cost mitigation strategies in place, maybe around the 6 to 15% of the population that are driving 15%. And that's so where you really need to start digging deeper into these charts to understand what's the underlying data behind it. Another piece of information that you want to look at is provider utilization. And again, a pretty standard report is showing what the top 10 or top 20 providers are, whether they're in network or out of network, what your spend is at those particular facilities or with those particular physicians. But here, you really want to drill down to understand that if there are multiple facilities in a given area, you want to really look at, is there an analysis that you can do from facility to facility? So as an example, let's say you have 2 hospitals in the area and they both have maternity care and they deliver babies. Well, you might want to do an analysis to look at what the cost of those similar claims are at both hospitals. And you might find that one particular hospital is actually double what the other hospital cost is. And this is a real example that I'm showing you. I'm not showing you the dollars, but this is a true analysis that we had done for a client. The same exact services rendered at 2 competing hospitals in an area, same quality outcomes, both in network, and one was actually twice the cost of the other. So this particular group started to get creative with some different incentives to offer to the associates to encourage them to utilize the hospital that had the lower cost. You know, so for example, you could offer a free year of diapers if somebody uses that particular hospital. That's just an example of a creative strategy. But that's the level of detail that you want to get into, especially around your provider information. Another key information that you want to look at, this is showing emergency room utilization, and we kind of refer to this as our heat map. So it shows the concentration of where people live and then where they're utilizing emergency room facilities. You know, so the question is, are the majority of ER visits out of area, in which case they're probably appropriate, or are the majority of people using the ER where they live, in which case then you need to drill down deeper into that data to understand why, especially when they're for conditions that, you know, you believe may be able to be managed by a primary care doctor, maybe even in urgent care. So this is kind of just like a high level picture of where those services are. And then again, you would drill deeper and deeper and deeper into the data to understand what's driving that behavior. This slide is showing, so this is our diagnostic classification chart. And we do this for all of our clients, and it helps us to understand what conditions are impacting the membership as well as driving the cost. So if you remember the chart that I showed you, the list that I showed you earlier with the top 10 conditions, this is really meant to show each self-funded group what their top conditions are. So in this example, you can see in the upper right quadrant, that's the condition or services that are impacting the most members and having the highest plan payment amount. And in this case, this is for routine care, which is exactly where you would want to see it. So this particular group does have high utilization of routine care.
But Laura, you don't want to stop there, because if you can remember back to the slide that showed the different preventative exams, less than 50% of the eligible population to receive those preventive screenings was underutilized. So we still could dig down and find out those individuals that are at risk because they're not seeking out routine preventive care.
Right. If you have, to your point, Donna, you may have a high population of dependent care,
right.
High ratio of dependents, where most of the time kids are going for their routine exams. You'd want to drill down into this to make sure that
Mom and Dad are going.
Exactly. But let's look at this by taking the routine care out of that for a second. And when you do that, it shows a little bit different picture. So in this case, it's showing that musculoskeletal conditions are impacting a significant portion of the membership and are also driving some cost. And at the same time, you also have respiratory services that not as costly, but are impacting a good portion of the members. So we're going to go into each category to talk a little bit about how you might drill deeper into that. So for the musculoskeletal, as an example, in this particular, for this group, we took all of their claims for a given time period and we analyzed what percentage of the spend was for what types of treatment options, so that you could kind of get a really good picture about what percentage is on chiro or physical therapy or on pain management specialists. The other thing that you'll see here is there's 51% of the spend that is for patients that have resolved their issue. And that's based on some analytics that we do to show what the length of time it's been since they've had a procedure done for that particular condition. So the one interesting thing, though, that I really want to show you on this one is that when you drill deeper into that 51%, what we found on this group is that 27% was really, even though the claims came through and had a back pain diagnosis, what it really was when you dug deeper into the information is that they were kidney stones. So they presented with back pain, probably in the emergency room, but the final treatment and diagnosis was kidney stones. So it's important that you drill down enough to really get a good picture of what's going on, because in this case, you know, the group may have spent, you know, a lot of time and energy maybe on
a list plan or, you know, a pain management program, when really they just needed their associates to be drinking more water.
Right, right. Could have had a water campaign. But, you know, that's why it's the just high-level musculoskeletal is not telling you enough. And even this isn't enough. You still need to drill down into these different treatments and look to see how many members it's impacting and what success rate they've had. And you keep drilling down and asking why. On the respiratory conditions, so we have, for this particular group, asthma is a leading diagnosis under respiratory for them. And if you remember, it was not on that list of top 10 conditions. And for this particular group, even though it's not high cost today, the concern is that asthma is impacting or affecting a good amount of the membership. And you'd want to drill down deeper to understand if it's the employee or spouse or children. And then the key, though, would be to make sure that those individuals are truly managing that condition, because if they're not, they're going to end up in the emergency room or urgent care, you know, needing some type of a nebulizer treatment. So even though it's not a top 10 for the country, this would be a condition that you as a self-funded plan, your administrator or medical management company should really be monitoring very closely to make sure that people are compliant. Health assessments. So I think the jury is out for some people on whether biometric screenings are impactful or not. We believe that they are, and for a couple of different reasons. First, when we're taking on a new group, we really like to highly recommend that people have the biometric screenings done. It gives us an early indication of any conditions that people may have and allows us to kind of get a head start on helping them manage those conditions. With a new group coming on, it could be 60 to 90 days before claims are actually submitted and paid and entered into, you know, the data warehouse in order to be able to have any kind of analysis done on it. So the biometric screenings are critical so that we can have as early of intervention as possible. The other reason for biometric screenings is that we know that there's a lot of people that don't have primary care docs, or even those that don't frequent them or don't get their routine care like they should. There's a stat by the CDC that says that 9.4% of the U.S. population have diabetes, but 24% of them aren't even aware of it. So they're walking around day after day with a condition that they're not managing because they haven't gone and had the appropriate blood work done.
And you know, Laura, I think this is such a critical component to these biometrics, is making the members aware of their condition. The awareness helps. One of the things we all struggle with is engagement, getting our members engaged in their healthcare and becoming good consumers in their healthcare. Once they become more aware of certain conditions that they may have, they begin to get engaged and seek out the appropriate care.
Right. I agree. Definitely agree. And as a self-funded plan, if people are accessing routine care and getting the routine screenings, you're paying for it as part of the plan. So why not pay for it and have access to that information and to be able to have the member see it as well? So the third area that we focus on is what we call connected company intel. And so this slide does not ring around the rosy, although that's what I think about when I see it. What we're trying to demonstrate here. Did you laugh, Marla?
Of course.
What we're trying to demonstrate here is that there is an untapped resource of intel from the people who are paying the claims, answering the phones, from the human resource department at the employer who's self-funded. There's so much real-time information that we can gain from those individuals. Customer service reps can see patterns. Claims analysts can see them way before the claim is, actually finalized and the information is uploaded to a data warehouse. Even the human resource department, they typically know if somebody's going off on disability or if they have FMLA, where that information, if HR knows somebody's going to be going out on disability or having a procedure, the sooner you can engage with the case manager, reaching out to that patient, the more proactive we can be and the more control over the cost that we'll have, versus just waiting for the surgery to come in and we find out after the fact, and then there's not much you can really do retrospectively. So we like to talk about our connected company intel is that everybody who performs any function for supporting that self-funded plan is part of our connected company, and they're providing us real-time information, to help us manage that plan. So, I think what we were really trying to convey is that it's not just about getting static reports and kind of looking at the surface of what the cost drivers are. It is absolutely critical that you look at the detailed information, your claims, your pharmacy information, any biometric screenings, and you keep digging down and you keep asking why. Why is this happening? Who is it happening to? And, so that you can have a better understanding of how to deal with it. And the other piece is to stratify that risk. So you may have some individuals that have conditions, but if it's not a huge cost driver, it's probably not something that you really want to focus on. So to summarize, we talked about our process. I do believe that you can have a disciplined process of identifying costs, creating strategies in order to mitigate those costs, and you execute on them and continue to evaluate the impact that it has, and then it kind of starts all over again. But I think the most important thing that I really wanted everybody to understand today is that if you don't have the cost drivers right, nothing else really matters. You have to understand what those cost drivers are, what the whys are behind it, and once you really have a good picture of that, then you can start to take action. So that's really what I wanted to share with everybody, was the cost driver identification. So I think with that, Marla, I don't know if we have any questions that came in.
Okay, thanks, Laura. That was awesome. Well, just a reminder, please be sure to type the questions into the question box in the control panel if anyone has any additional questions. But I think we do have a few. It looks like our first question is, how do you convince employers and health plans to spend money on biometric screening? That's a good question.
Yeah, okay, so that is a good question. Again, I do think that the jury is out for some people about whether they are really impactful or not. I think that, like I said before, a self-funded plan is encouraging people to have their routine care and have routine screenings done. And the plan is going to pay for those screenings anyway. So the key is to encourage people to pay for the screenings and have the ability to do something with that data. So, if you need to really, I guess it's very important that you actually use the data and create strategies from it. Otherwise, I would agree that there probably is no point. But when you're using the data and you're looking at it from an aggregate basis, it's going to help you to understand what percentage of your population is at risk for certain conditions. To Donna's point before, I think it really helps people get engaged, because if they haven't gone to the doctor and they're not aware of it, this might be their first indication that they have a condition or something going on that needs to be addressed.
And it's not necessarily a more expensive cost to the health plan. We did some analysis and looked at the cost of an in-network provider sending someone out to get lab work done, and it's very comparable to most of the biometric screenings that are out there today.
Yeah, actually, the one analysis we did, it showed that the PPO fee schedule would have been about $400 if all of the blood work had been done, and I think it's like half the price or less than half to have the biometric screening done. So I think it's case by case. I think I don't think there is really one answer to that. I think it's really just sitting down and understanding what the goals and objectives are for that self-funded plan, and how we can help them, and how those screenings can really come into play as a tool to for that cost identification.
Okay. Well, I think that covers all of our questions. Laura or Donna, is there anything else you want to cover before we wrap up today?
No, nope, I'm okay.
Stay tuned.
All right.
Right.
That's right. All right. Well, thank you, everyone. And again, hope you'll consider joining us for future webinars in this series. In our next one, we'll be discussing how to build customized plan strategies in more detail, and focus on areas of risk in a plan. So until next time, thanks again, everyone, and have a great week.
Thank you.
Thanks,